this is Michelle from the snooZze Clinic and welcome to another episode of Sleep Talk. Yes, it's me. It's just that my hair has grown much bigger, but yes, it's still the same old me. Yeah. Okay, I know it's been a long while since our last episode of Sleep Talk, and I apologize for that. Well, we've all been really busy, so it's very hard for us to fit the recording session into our schedule, yeah. But I'm gonna make it up to you in today's episode. How? Okay, in today's episode, we have a very special guest with us. He's none other than Prof Ronald Lee from the National University Heart Centre, Singapore. Prof Ronald Lee is a cardiologist with a special interest in the interactions between cardiac health and sleep, or the lack of it. Yeah. So, well, let's hear from the horse's mouth the cardiologist's point of view on OSA and how it affects our cardiac health and how it affects us as a whole.
Heart disease is certainly one of the major killers in Singapore. Based on the Singapore Heart Foundation statistics, we know that on average, every day, we have approximately 20 people die of heart disease in Singapore. Moreover, heart disease accounts for 1/3 of all deaths in Singapore in the year 2020. If we look at patients come in with heart attack, for the National University Hospital where I practice, every day we have approximately 5 to 10 patients coming in with an acute heart attack, and many of them require emergency ballooning and stenting procedure. These two conditions are very closely related. In fact, for obstructive sleep apnea, or in short we call it OSA, it is a chronic disease whereby there's a recurrent collapse of our upper airway during sleep. And that means that whenever we go to sleep, our airway collapses, and therefore the air cannot go into the heart and lungs smoothly. And in the middle of the night, a lot of patients would develop severe, we call it hypoxemia, meaning that the blood oxygen level drop to as low as sometimes 60 to 70%. And this kind of hypoxemia imposes a severe stress to the heart and the blood vessel. And this causes increase in the blood pressure, and in the long run leads to a variety of heart condition, including heart attack, stroke, heart failure, and sometimes irregular heart rhythms. So these two are very closely related. So for the past 10 years, my teams and I at the National University Heart Centre, Singapore, have carried out a series of clinical research projects to look at how untreated obstructive sleep apnea affect heart disease patients. Altogether, we have recruited over 2,000 patients who have coronary heart disease, who need to undergo either ballooning and stenting procedure, or in more severe case, undergo open heart bypass surgery. And we found that approximately 40 to 50% of these heart disease patients have obstructive sleep apnea untreated. And when we follow up this patient for the next 3 to 4 years, we found that those with obstructive sleep apnea have a 50% higher risk of developing something we call adverse event, meaning that these include things like heart attack, stroke, or admission due to heart failure. And that actually imposes a lot of stress and to the cardiovascular and health system in the public health setting. Well, certainly OSA is very common in Singapore. We previously reported that 1 in 3 Singapore people have obstructive sleep apnea. We know that people above the age of 40, especially for male and who are obese, they are more likely to have obstructive sleep apnea. And common symptoms include snoring during sleep. Some of the patients complain of headache in the early morning when they wake up, and many of them feel very sleepy during daytime, and they often have to take afternoon naps. So these are the typical patients with obstructive sleep apnea. Well, certainly this is a topic under active investigations. At this point in time, we do not have strong evidence that we need to screen everyone, every heart disease patient for obstructive sleep apnea, because we have no strong evidence that will help every patient. But I would suggest that for those heart disease patients who are obese, who snore, who feel very sleepy during daytime, especially those who have hypertension, to undergo an OSA screening and treatment as well. Currently, the gold standard to diagnose OSA involve a investigation we call it PSG, which stands for polysomnography. PSG involves a patient sleeping in a so-called sleep laboratory, typically located in a hospital for one night. During that night, the process is being monitored and recorded. So after the night of sleeping in the sleep laboratory, then we would be able to look at the tracing and tell whether the patient have OSA or not. This is a very pertinent question because there have been more and more smartphones that could record and report sleep parameters. But from a medical doctor's perspective, these are not medical grade device and equipment, and therefore I would feel that by itself this device is not able to definitely tell whether you have OSA or not. But in my practice, I do encourage patients to make use of this smartwatch and smartphone to develop a good and healthy lifestyle, and more importantly, make use of the device to take ownership of their own health and their own habit. Well, for now, the so-called gold standard for the treatment of OSA involve wearing a CPAP at nighttime during sleep, which is like wearing a face mask to sleep. This is being recommended as the first line treatment, as it is effective. However, in our practice, we also know that approximately 30% of the OSA patients, they either do not accept CPAP or find it uncomfortable after trying it. And for these patients, then there are alternatives. For now, the alternatives include wearing a mouth guard, or we call it mandibular advancement device, to sleep. And the other would include a surgical procedure of the airway. So these two are currently being recommended as a second-line therapy. The good news is that hopefully by beginning of next year, there will be a new treatment available for patients in Singapore, and I'm referring to the a implant procedure that involve putting in a device that is something similar to a cardiac pacemaker to the chest wall, and the device is able to regulate the upper airway opening during sleep. So after the implantation of the device, then the patient may not have to use the CPAP or the mandibular advancement device. Certainly, as we know that OSA is mainly due to overweight and obesity, and therefore definitely yes, I would say if a patient could reduce weight effectively through diet and exercise, it does help with OSA. But at the same time, we also notice that losing weight to the extent that could completely eliminate OSA is really very difficult, and sometimes even harder to maintain it for a long period of time. From a heart doctor's perspective, treating OSA is very important, especially for patients who have hypertension, because it has been shown repeatedly that treating OSA is able to bring down the blood pressure and improve the control of hypertension. But at the same time, I also hope to highlight that so far it's unlikely that by treating OSA alone is able to make you do away with the blood pressure medication. You probably still have to take blood pressure medication, but with the OSA being treated, is able to control the blood pressure better, and that will lead to a lower risk of developing heart attack and stroke. And then another thing what we know is that treating OSA has been shown to be able to make you sleep better and make your bed partner sleep better as well, and people's quality of life in general improve after treating the OSA. Well, this is because of the heart failure, and we know that central sleep apnea is a related but a different disease from obstructive sleep apnea, and it mainly happens in patients who have heart failure, and unfortunately, a patient with central sleep apnea usually have a not so good outcome if they have heart failure. Currently, the treatment of central sleep apnea is mainly depends on the treatment of the underlying heart failure condition.
Thanks, Prof. That was very enlightening. Thank you so much for sharing it with us. Okay, I've got a little confession to make. I forgot to ask Prof Lee to explain or to elaborate on central apneas and heart failure, and how heart failure actually contributes to central apneas, which is what I wanted to know today. Okay, so from time to time, we do have patients who ask us that question, right? Because they are always told that, oh, your centrals are very high, but hey, it's expected because of your heart condition. So patients are like, yeah, okay, I know that my centrals are high because of my heart condition, but why? So I've never succeeded in coming up with a satisfactory answer, so I've never even tried answering them. Okay, so as a last resort, I did some reading earlier, and I'm going to attempt to explain it in the simplest form, which is the form that I understand. Okay, so I'm very sure whatever I'm going to explain is way more simplified and way more summarized than what actually goes on in our body, but this is the version I understand, so this is the version I'm going to explain, okay? So, okay, firstly, heart failure, right? So heart failure happens when the heart muscles are weakened, yeah? Causing it to not be able to pump as efficiently or as effectively as a normal heart with healthy heart muscles should. So for example, if a healthy heart goes like whoosh, whoosh, right? a heart with weakened heart muscles may go like, yeah, something to that effect. Okay, so now we take a look at a patient who's asleep, right? Asleep, flat on his back. Okay, when patients asleep in that position, venous return from the extremities, which is your hands, legs, yeah, everywhere, increases. So can you imagine now we have increased venous return, but on the other hand, we also have a heart that is unable to effectively or efficiently pump as it should. So what's going to happen is there's going to be accumulation of blood, right? And when that happens, blood's going to back up into the vein that brings blood through the lungs. And that when that happens, the blood pressure within the vein is going to increase, and what it does, it's going to push fluid into the air sacs, into the air spaces in the lungs. So when the air sacs are filled with fluid, right, gas exchange is impaired because the air in the lungs can no longer move like they should, right? Because of these little, because of all the fluid within the air sacs. Yeah. So when that happens, it triggers this reflex and it makes patient hyperventilate, right? So when patient is short of breath, they start to hyperventilate and they'll go like, right? So when they hyperventilate, the partial pressure of carbon dioxide actually decreases, right? It falls. But when it falls below the threshold that is required to stimulate breathing, the central drive to the respiratory muscles and airflow stops. Temporarily, not for the whole night, temporarily. And this actually goes on and on throughout the whole night, which explains why patients with heart failure tend to have a high number of centrals. Yeah, and that is also why, as Prof Lee mentioned earlier, central apneas are a different ballgame from obstructive apneas, right? You don't need an obstruction for a central apnea to occur. You don't need a floppy soft palate. You don't need humongous tonsils. You don't need a fat tongue to actually cause a central apnea to occur. It just occurs because it's an issue with the message that's sent down. The central drive to the respiratory muscles actually stop. So that's my simple summarized version of how heart failure is linked to central apneas. I hope it was short and sweet and clear enough for you. Okay, if you have any further questions pertaining to whatever Prof Lee has shared or my explanation, please feel free to write in, right? And we will get the respective medical professional to address your queries, your questions. Yeah. So I think that's all for today. I will see you soon. Hopefully it's not gonna take as long as what it took for us to come up with today's episode. Yeah, so see you, take care, and enjoy your coming weekend. Bye.